Welcome to a conversation by Child Health Advisory Council, a group of former and current, mostly current leaders in pediatric child health and academic pediatrics. Today we're addressing a very important topic of the well-being of faculty. As we all know, this is a critical nature, and especially in a time of shortage of pediatric medical and surgical specialists. Today, leading a discussion on faculty well-being is Dr. Annika Ashraf from the University of Alabama. Thank you, Annika, and I'll turn it over to you.
Well, thank you, Bruder, and thank you all so much for being here. Today, as Bruder said, we are exploring one of the most relevant challenges in academic medicine. How do we sustain well-being of people we lead? And we all know that burnout rates are very high in health professionals. And I also want to emphasize at this point, because I sometimes get confused, the well-being is really more than absence of burnout. It's the presence of purpose, connection, and balance. So most of us chose this work for establishing meaningful patient relationships, teaching, giving time for intellectual pursuits and problem solving by research. Yet we often feel like we are pulled in many directions, pulled by the clinic, being on call, teaching learners, research, and just life. The question is, how do we honor these commitments while maintaining quality and balance? So we are hoping today we will go one layer deeper, share reflections and practical insights. And I'm going to invite my co-leaders, Chris and Peggy. Chris, may I invite you to share your reflections next, and then we will turn it over to Peggy. Then we will go to our 4 questions. Thank you.
Thank you very much, Dr. Ashraf. And I agree, as the surgeon-in-chief at a freestanding children's hospital, burnout and wellness, for as disparate as they may be, seem to be hot topics of discussion. Across the faculty, we send out surveys every year to see what the level of burnout may be. And every year, frightened because it seems to be that the pendulum is shifting a little bit more towards the burnout side. And, I'm constantly struggling to figure out how to address that. And it's exactly as Dr. Ashraf says, it's the combination of the pressure for work, the lack of reimbursement, the struggle for work RVUs, as well as we just had a whole talk about academics. Most of us have gone into this profession because we love science and we want to continue to improve the health of children and the well-being of children. And so that sometimes takes research. And how do you fit all that in when you are being a real adult, as I say, and having a family life and having outside responsibilities? So I think it's a topic well worth our discussion. Thank you for asking.
Now we'll hear from Peggy Troy.
Hi, I'm Peggy Troy. I'm the retired CEO of Children's Wisconsin and also a pediatric nurse. I led Children's Wisconsin for 15 years. And I will tell you, this is a topic that we discuss often about how do we attract the best and the brightest, and then also fulfill not only their professional lives, but help them fulfill their personal lives. And, burnout is real. We don't always like that terminology, but it is. And in my career, I've seen about 3 different generations go through it. And I think that the sensitivity around the up and coming generation really has to be taken very seriously, because we're trying to attract those that will replace us to make sure that they have fulfilling careers, can also balance the demands of their personal life. And I would say that it is very individualized. It is not a one size fits all. And I think the dynamics have to really consider that individual preferences, priorities need to be taken into consideration as we're thinking about the solutions. Surveys help, but I don't think that's the only way that we can really gain insight and understanding about what it's really going to take in order for us to help people feel professionally and personally fulfilled, because we know the better you feel in your professional and personal life, the better outcomes for the kids. We're going to do better at our jobs. We're going to make less errors. We're going to be more intentional about what we do. So I would consider this to be a top of mind, a top priority for not only the faculty, but also the hospital administrators to solve this big dilemma that I think we're facing. I think it's increased in the past several years.
Thank you for sharing that. So now we will go to our first question. This is a big one. The question is, when you think about faculty wellness, what does faculty wellness actually mean to you as a leader? How do you tell the difference between being busy, being stressed out, or being burned out? Let me go to Chris for her initial thoughts.
Thank you very much for that question. For me, faculty wellness means that you have faculty that seems connected, that they are working together in harmony, and that they seem to be proud to be coming to work, that it's not something that they dread. Everybody can be busy and stressed, usually you're recognizing that as a short-term issue, right? You're busy because you have a high patient population or something along those lines. Burnout is much different. Burnout, when you see burnout in the faculty, it's more the helplessness and the hopelessness. And that's what you want to try to prevent and address immediately.
Thank you, Chris. That's really insightful. Now, I'm going to ask Peggy, as a hospital CEO, you probably lived through some of it. Could you reflect on how you sustain yourself and each other as a leader? How did you manage it? Please give us some examples, tips, and techniques.
Well, what I did, first of all, I knew that when I had children, balancing out the work requirements of being a CEO, plus then also the purpose in your life to raise your kids. And what I tell all young individuals who are facing this is you can never go back and raise your kids again. So when you have to think about your prioritization in the stress of work and all the demands and you want to perform and all that, you always still have to remember that you have a responsibility towards your own family. I was fortunate that I have a husband who understood that balance, and we would divide up tasks and responsibilities. And I think the cooperation in the home life is a really important thing to figure out as you're going through all this, because the demands are intense. And it's a job where you are really responsible for saving kids' lives, right? At the end of the day, we're making kids' lives better. And so what I really tried to do was make sure that I put my priorities right and that my objectives and my goals were realistic and that I could accomplish that. And then I had to surround myself with the support services. I was fortunate that I had grandparents that were very, very attentive to our kids as well. At work, we have a saying at Children's, it's called "Be Here Now." And I really believe that when you're at work, you have to be there and to really focus on what the priorities and objectives of the work were while you were there. And then really try to prioritize your time. I think one of the things that leads to burnout is the demands beyond the day at work. I mean, you come home, you've got to do charts, you've got to do emails, and all those kinds of things. And how you then really can prioritize your time, get the things done that you really need to do for work and for home are really an important consideration. And in some cases, maybe you all don't agree with this, but sometimes you have to say no, because you can't do all things for everyone. And again, it's really hard to say no, but I think sometimes you have to learn the art of that and also learn where you can surround yourself with others who can support the work you're doing.
Thank you for sharing all of those. These are very helpful. And I would also love to hear some comments from the audience if anyone has comments.
I was struck by a comment that someone made earlier about connection and how important that is. And, you know, that some of that is connection with patients, which can be, of course, very, very gratifying. But a big part of it is also connection with our colleagues, as was mentioned earlier. You know, it's maybe a little bit too black and white, but I've heard people talk about how this problem of joy or lack of joy in the workplace is related to either systemic issues over which an individual has little control, one's own resilience. And a lot of the efforts that have been made in the last few years have been focused on physician resilience. And I don't mean to demean that in any way, because I think those can be really important strategies. One of the most important in my experience is being able to appreciate and express gratitude. You know, even when you're pulled in three different directions, if you can take a step back and say, wow, I was a surgeon before retirement. You know, when you say, wow, we did a great operation and had a very successful outcome. And families really happy. That can nourish you if you're able to take that step back and appreciate that and really be purposeful about expressing gratitude. On the systemic side, as leaders, I think it's probably our highest priority right now is to try to identify what the barriers are to do, as Peggy said, stay connected, be present in your work, get done what you can get done, and not take a lot of work home. So I think it's really important for us as leaders to focus our peak energy on how we can remove those barriers. I think there's a lot of great work being done around the country in that regard with, scribes and now artificial intelligence to facilitate clinic notes and so forth. Those are all great steps that hopefully will start to pay dividends here in the near future. So that's just some of my thoughts.
You have pretty much covered a lot of our discussion, like covered majority of aspects as to structural aspects and also establishing at a personal level how we can improve, and also you addressed gratefulness. So thank you.
I think for the junior faculty, the number one thing probably to keep them, happy. I agree. You want people that are work that are happy, enjoying what they're doing, but is to actually give them a sense of control over what they're actually doing at work. And I think that's the biggest thing that's missing in the modern era. I mean, they're kind of told you're going to do this many clinics, this much call, this many lectures. There's no sense of control, and I think that's the real key. So as a leader, I think it's critical. We talk to our faculty, junior faculties that come on. They may have a subspecialty interest, say, okay, how does that fit in with the folks that are here? What are you thinking about? We try and get their vision and image first. And if they don't have one, we tell them actually to think about it, maybe talk to the other people that are doing that, but to try and come up with that. Because the reality is I can tell them what I want them to do, but they're going to be much happier if they come up with it from a practical standpoint. And I think that's critical. The other thing we try and do, and I think this is one where there's still a lot of work, is to kind of minimize, because the other big factor is kind of what physicians perceive as unnecessary work that a physician doesn't need to do. So all the stuff in clinic that a nurse, an MA, anybody else could do that's part of our new electronic record, I tell them, don't do it. Get those people to work at their level. If you do it, they will gladly let you. That's human nature. We'll all be happy to let someone else do something for us. I'd love it if my neighbor mowed my yard and his, but, let them, make them do it, let them do it in a nice way. But I think we have to push, because a lot of our junior faculty really think like, oh, I guess I'll do this because I was doing this as a fellow resident, you name it. And they just continue in that mode. And then they're unhappy because, as Peggy said, they're going home and they have, 30 minutes, an hour's worth of stuff to do, to make up for their clinic day when they'd rather be with their kids. So I think we really have to minimize that in a huge way as much as we can. And we can work a lot with our IT folks, our administration, the nursing clinic staff to do that. Yeah.
Well, and Jim, that's an important point, because what I hear too is, while the electronic record has been a great asset, it's also been, in terms of your time, a liability.
Yeah, and I think a lot of the faculty would view it as a nightmare more than an asset in many days. So yeah, I agree. Yeah.
And I think we have to appreciate that. And okay, so what's driving that? What makes that become such a burden? And I think the access to your email and to your charts and things like that at 24/7 increases your feeling of responsibility to respond. I think one thing we could stop doing is sending emails after a certain time at night. That is a huge burden to people when they feel like they've got to respond quickly, especially if you're a junior faculty member. And I think as role models and mentors, I made it my policy. I did not email my team after 6 p.m. if there wasn't something urgent, because I let them go home with their families and be part of that other part of their lives. And I think the mentoring that we do as their bosses really cast a big shadow on how they feel they need to show up in their jobs as well.
There is one comment in the chat. A lot of what we discussed in the last about mentoring absolutely applies to promoting assuring wellness in faculty. They do need to form a connection, and that their mentor chief colleagues care. It does require building a culture of support. I couldn't agree with that more. And then I suspect a lot of us on this call appreciate some of the important components of wellness, humanism, and how we can, as leaders, take away some of the responsibility from them. As some of you who are on CPC in 2005, October was named committed to having a humanism in medicine talk every year after they died on the way to a Kirksville to give a talk conference. Interesting. I didn't know about that, but yeah, being humanistic and forming those connections. I mean, I think that's where it comes to. And the problem is that you have to make the time to do it. You have to be deliberate, and especially as leaders, make the time to enable people to get together. The question number 2 is, how can we rebuild connections and community among faculty with everyone stretched for time and under our view pressure? I think it's really what I just stated. You have to make the time, find the opportunities. And as leaders, we have to carve that time out during the workday so that faculty can come together. Recently at Connecticut Children's, we just had a large EMT retreat where we invited all physician division chiefs as well as all directors across the organization. We had to rent a space because it was a lot of people. And we spent a whole day in the retreat. Now, yes, did we, was that a financial investment? Absolutely. But I think what happened when we came out of it on the flip side is that people formed better connections. And there was a more of a sense of engagement within the organization. I can't say that there was more of a sense of wellness, but there was definitely much more connectivity and people working together. So I think it's important to make the time to do that.
I'd like to build on that a bit, in that so much of especially medicine is cross-functional among the disciplines. And I think the other thing we have to think about is how we treat one another. So if you're in the ICU and you need to call surgery, or you're in one of your clinics, and so many of our kids are multi-specialty kids. I know that giving others the time that they need to correctly diagnose and treat their patients when you're one of the other specialties that have to engage around that patient is incredibly important in order for people to feel good about being able to call you and ask for your help, but then also for your expertise to add to the pool of needs so that you can provide the correct diagnosis and treatment so the patient gets better.
I think we've been doing this with different solutions to it over the years on wellness, but it's pretty clear that if we don't take care of each other, both in our families, we're not going to be very good at getting through the stresses of academic life. It's things change too fast.
This particular question made me think about the Surgeon General Vivek Murthy's framework for 5 essentials for positive mental health. So of which 2 of them were connection and community and mattering at work. So that's what it really resonated with me when everyone was talking about connection, belonging, and community. So at UAB, I'm curious what other institutions do. At UAB, we have Office of Wellness. For example, they provide research, education, individual support of wellness. There are also wellness champions in each department. We also have a newsletter called Take 5 Tuesday that names 5 short articles. It takes 5 minutes to read them. So some of those articles are interesting. For us in our division, for instance, we tried to bring connection to work, like monthly faculty dinner. We also have even a group chat where we discuss about family life, kids, or something else. So that also I felt established connections. We have weekly case discussions. We also have clinic flow meetings. All of them since COVID, what I realized is we are really hungry for connection. And for me, all these connections creates an extra sense of bonding. So I'm really curious as to how other institutions have sustained these practices. I would leave it up to the audience if anyone would like to comment.
I think the points you just made were spot on. And there are skills associated with communication that I feel as though we've neglected over the last few decades. And part of that, I think, is so much of our communication, quote unquote, now is virtual. It's electronic. And that's not real human to human connection. I suppose it's better than nothing, but I think the skills of communication are something that we need to spend more time and attention towards. I say to many people, I wish that I had been directed to the book Crucial Conversations at an earlier stage in my career. Because there are skills in that book and in similar sorts of training programs that really enhance that connection and bring with it gratification and understanding. And we tried to start something like that at Seattle Children's that we called the Connect program. That was originally intended to be training physicians to improve their connection with patients. And what we soon realized is that it also, if done correctly, would enhance communication with one another and improve collegiality and improve, those unfortunate situations where conflict occurs. Communication skills can mitigate that. So I think that's a really important thing for us to think about in terms of medical student and house staff education.
So we're seeing a generational shift from our younger faculty and what they prioritize as their needs, how they think about work-life balance. And it's different than many of us when we were earlier in our careers. So we want to talk a little bit about how institutions have adapted to this generational shift. As I mentioned in the beginning, I've seen 3 different generations come through in terms of work-life balance and how are we going to go about that. One of the things, my observation is that some of us that are definitely in the more senior generation, think that people that are complaining about too much work or difficulties with work-life balance, that they're just they're not committed enough or they're whining or whatever. I see this change in this upcoming generation as real. It's different. And it's something that, as we've all said, we absolutely need to pay attention to, because I think what it's going to do if we don't is it's going to discourage people from going into medicine, pediatric healthcare, and we already are facing the workforce shortages that we see. So I think it's really important that some of us in leadership positions need to really change our thinking. I remember when I first came to Children's, many years ago, I had a surgeon tell me, unless you've operated for 30 hours, you're not a real surgeon. Of course, my response is, if you've been operating 30 hours, I don't want you operating on my kid. But we went round and round about that very point, because, if we expect that these younger people coming in, whether we like it or not, are going to work 30 hours in the OR, we're wrong. I think that demands are changing. The sentiment about healthcare among people has definitely changed since COVID. I think the pressures coming from the external forces are much different than they were. You couple that with all the demands of the job, home life, et cetera, it's time to really pay attention to this. And as I mentioned in the beginning, I think that this is an individual issue. It is not one size fits all. So beyond the surveys, wellness coaches, et cetera, I think are a nice asset that many institutions provide, so that they can talk to the individual, especially when you start to realize somebody's, coming late to work, or, is missing important signs and symptoms, et cetera, that we're getting to those people early, because I do think it affects their mental health if we don't.
I think there was an emphasis initially with wellness on sort of resilience and individual things that you would try to do. And I think that's a balance between what the institutional responsibilities are toward the faculty. And I think that's kind of what Peggy was, many of you have been mentioning that. And one of the things that we did at CHOP was we started tracking who was signing on to Epic after 5 o'clock. And we looked at it by division, and we looked at it by individual. And then we sort of assigned a group to look at that and try to reduce that rate in terms of carrying things home with you, seeing patients all day, getting dinner, getting the kids back, bathed, and then finishing your charts. Another comment is that each division at CHOP have support a group of people to do wellness, and their time is supported, and they are required, or they're expected to develop divisional wellness activities to try to help gather people together. Some divisions now have huddle days because there's so much remote work. They've designated days once a week or once every other week as a day when they would want everybody to come in and try to make those connections. So it, it doesn't all work perfectly, but I think there is an institutional responsibility that I've seen that I think really should be expected and developed related to wellness.
I would just say, I really appreciate the emphasis that's been brought up with regards to going beyond resiliency, and that the climate and interventions really need to be diverse with regards to who you're serving within your faculty and your population. And then what I wanted to add from the perspective, especially if we're talking about burnout and well-being and a transition that I've gone through, even over even the past 12 to 18 months, is really taking us a step beyond the perspective of well-being and wellness, and really emphasizing our health and our morbidity and mortality. And I say that from the perspective of myself I gave a presentation at our Peds Academic Societies meeting about the impact of being in academic medicine. And despite having submitted the proposal beforehand in February of 2025, there was an original investigation on physician workforce environment and well-being published in JAMA Internal Medicine. It was the first study that looked at vital statistics, population-based registry for physicians. And the results were, I think, just chilling. Despite most healthcare workers having a lower age-adjusted mortality rate, that didn't extend to physicians. Female physicians have higher mortality than male physicians from cancers and lower respiratory disease. And that's regardless of income. That was the same for physicians and health workers who are from Latino settings. This was an incredible cross-sectional study that showed that although physicians and most healthcare workers experience lower mortality rates compared to the general population, that benefit didn't extend to women or racial or ethnic minorities. That was quite chilling to me to learn that. And when we think about the stressors, not only the stressors of being in our undergraduate situations, our medical schools, our residencies, we talked about like working 30 and 36 hours at a time. Our telomeres were getting shortened and our DNA was getting methylated, and it continues when we are when we have young families having children and working 12 to 18 hours a day at work and then going home and doing the same. So I really do think taking that conversation beyond the perspective of well-being and burnout prevention, and really focusing on health. We're seeing, and I don't know if you all think about those who are in your own settings and maybe colleagues who have left us sooner than you would have anticipated, who have had different health outcomes. What we really are doing to ourselves in these environments of kind of stress and toxicity, and what can institutions do to counteract that? It really is, it's a, how do I say, it's a cumulative effect. And so I would say that's one of the things I really appreciate about this younger generation, kind of getting it now. It is a cumulative effect. And I've tried to emphasize that if they don't start taking care of themselves now, some of the stressors that they are experiencing and that's impacting their well-being, mental and physical, can actually impact their morbidity and mortality. When they're at the age of retirement, are they going to even make it to those stages? And I'm really shocked at the number of those in our colleagues who are in health professions and really high stress academic health professions who are not.
And my comment or question has to do with again, this thing about looking on how many hours people are spending charting after hours, what they call the quote unquote pajama time. And so here at Children's, they've started looking at that. And, they'll just, like you say, break it up by division and send it to you. what I struggle with is then what do we do with that information? You know, you can't just say to the person, oh, look, you're doing 4 hours of work after you get home in the evening, stop doing that. We have to give them some type of resources to address that. And one of the interesting juxtapositions that I saw several months ago was they rolled out new rules in terms of timely chart completion. You know, that 7 days, and then if you get to 30 days, you know, it goes all the way up the chain. And then I think it was the following week that they sent out the physician well-being survey. And it's like, do you see the conflict here that you're just sent out these new demands, and then the next week you want us to fill out a wellness survey? So that's where I struggle. Is absolutely we want to do this, and couple that with what Dr. Mcneal-Trice just said about impact of all of this. So we're gathering data and not doing anything about it. It reminds me of, you know, as a kidney doc, we have all this data that's been collected over the years, again, looking at minorities and the disproportionate impact, and just a lot of data gathering. We finally have gotten to the point of some studies that are actually trying to now do something. And so I worry the same thing about this wellness piece. What do we do about it? We have all these data, and what do we do?
I really agree with that comment. I think it's one thing to track the data, right? And another to, well, what the heck do you do to support? And I guess that I do think that there's this institutional responsibility to find the solution. What we've done with that data is we've tried to change the templates and the requirements for documentation and make them less, while at the same time, you know, the billing and the communication that we need to do with the electronic health record remains the same. The other that we've done, which I'm really excited about now, is that and AI is contributing to this, is the physicians can just start recording their interactions. We're doing this both on the outpatient side and the inpatient side. And at the end of the visit, it's not just a transcript of what was said during the visit, but it's the note that's been written. It's pretty remarkable. We're still being really careful about what those notes say to make sure that they're accurate and they don't need to be edited, but it does save a tremendous amount of time. And I think it's only going to get better as time goes on. But again, I think this, as you were commenting, it's really the institution's responsibility to provide that type of support, to provide that type of expertise, to try to do everything we can to reduce those burdens.
I think the one thing, in addition to what Lou just mentioned, I want to add is the last decade, I think we went from, in Cincinnati, from calling out the people who were not good at finishing their charts as away from that to saying there must be something they need help with, and individually trying to either use our mentor program, our mental health providers that can be available, or even just because I think that's that's much better at helping on figure out where to go. And I know that this is not HIPAA protected, but I know that it wasn't that long ago, 15 or so years ago, where someone literally lost their position because they probably had OCD, and when they dictated reports and pathology, they couldn't make it perfect, and it took forever for them to close records. That kind of stuff is really much more about helping the provider as opposed to punishing the provider, and we really need to become masters of that in a better way.
That's a great point. I would also like to share my experience with the AI scribe. So in our health system, we recently started using DAX, which is an AI-driven scribe, which is like a co-pilot. initially I really didn't think I would need it because I had excellent templates and I was like, I'm a pretty good charter. So, however, I thought skeptically, I actually opted for this AI scribe. What's fascinating is, as somebody was sharing, many of you shared, by the time it records everything, organize it into HPI, result section, physical exam, assessment and plan. And I also realized I actually talk a lot about our plans to the patients. And when I'm putting it as a template, all of those really doesn't come into the chart or my dictated note or my written notes, but this AI scribe really put all of them in detail. By the time I'm getting out of the room, the note is done. So it has really made a big change, and also in capturing everything I have really done. So I felt, I echo with everybody, the real levers of wellness is institutional, structural. And so I also want to add that beyond efficiency, people also need to feel that the work matters. There has to be recognition, fairness, autonomy. Those are also something that the leadership could do and provide. So that will also to echo that physical well-being and also mental well-being is also so important to prevent inflammatory milieu and also like prevent epigenetic changes. We were just talking about yesterday, most of the childhood neurology tumors, brain tumors are a result of epigenetic changes. And we were like, okay, so their parents could literally transfer all of those, whatever they have suffered during puberty, that would have changed their methylation patterns and that could result in. So we want to protect our physicians and clinicians. So I completely echo with everything that everyone said. And then I don't know if we have time for the last question. So last question is, how do we know any of these wellness efforts are really making a difference? And we know some institutions use surveys, checklists. What would really success of these measures would look like you? What would a well organization look to you?
I mean, I was thinking about that when the analogy was made to the morbidity and mortality. And if we view this as a nationwide epidemic, we're at the point now where we're throwing lots of different seemingly good ideas at the problem. There needs to be some rigor and study to identify which of these. I mean, for example, the artificial intelligence scribe may be a great intervention. Will it measurably move the needle? I'm not aware at this point of any good studies to show that it has. This is something begging for a nationwide interventional study.
I agree with Dr. Sawin and studying this rigorously with the different methods that people are using to throw at the problem is important. But I also think he highlighted one other thing. The quality of your program will be better because if you have a well faculty that's engaged and feeling that sense of wellness, your morbidity, mortality, your quality metrics will all be, the best to be benchmarked, and your employee retention will be high. And so looking across the board at those institutions that may have really good metrics based on those factors, and then asking them what they're doing for their faculty might be helpful.
I agree with everything, and this may be anecdotal, but perhaps would lend to the effort about rigorous study. I think a lot of times institutions will put in interventions that will help individuals do their work in the workplace better. I can tell you as a former chief GME officer and DIO, having trainees across multiple hospitals, some of the most raving compliments about workplace interventions actually helped when institutions put in resources that helped individuals with their personal life outside of work. And so like a credible example of that was with health systems that put in concierge services that would do your grocery shopping for you, pick up your dry cleaning, take your car to get serviced while you were at work. Like you had something you need to mail, you could just bring it to work. They would mail the package for you. Like they had they called it a concierge service that would do this for you. And it was like the trainees were like, it was like they felt like they were in Oz. Like it took this incredible pressure off of individuals that don't work a 9 to 5. We're doing something 24 hours a day, 7 days a week. And the joy and the sense of belonging that they gave us from that feedback was incredible. And so it was an institutional investment in their responsibilities outside of work, made individuals more present. They felt like they belonged more, and their stress and burnout level declined. So it would be interesting to see even more cross-sectional studies across that nationally if other places do similar interventions. I think we've seen it in Silicon Valley and other places. It'd be interesting to see it in the healthcare setting and academic medicine.
Dr. Ashraf, that also raises a question of this problem is not unique to physicians, and burnout is seemingly epidemic or pandemic in all of healthcare. So I think we've got a lot to learn in a lot of different spaces in the industry.
That is so true. I'm hoping that all of these discussions, even now we have learned so much about all of these conversations, the adverse consequences of that for health, well-being, longevity, so many things we have learned. I'm hoping all of these reflections, they will ripple forward and we'll gain more insights. It's probably going to be an ongoing continuum of efforts that we have to frequently change our strategies and learn from it and go forward. Thank you all.